Good morning, my name is Jorge Gomez. I'm a student from South University and doing my FNP program, and today I'm here to do my head-to-toe assessment. And alright, good morning. My name is Jorge. How are you?
I'm good.
What's your name?
My name is Eric.
Eddie. How old are you?
20.
20. Eddie, who's the president?
Donald Trump.
Okay, perfect. Why are you here for? What's the reason for being here? Wellness?
Yes.
Okay. Is the patient we see is a 20 years old male, Spanish speaking. So in some point of the exam, probably I had to translate it. So probably you're gonna hear me hear me speaking in Spanish. So that is part of that's my assessment too. Sorry. And we see is a patient according to the age, 20 years old male, with no sign of distress, well speaking, clear language. And now, before continuing, I'm gonna explain you that I did my hand hygiene. I washed my hands pretty good. And all right, continuing with my assessment, I want to let you that. First, I'm gonna explore the head, and in the head, I'm gonna look for any abnormality, any alopecia, or any infestation that I can't see visible. In the head, I'm gonna use my glove, and the reason is because I wanna touch the hair. So in this case, I'm gonna palpate the head, looking for any tenderness, any sign of alopecia, or any abnormality on top, or any cyst. In this case, negative. Continuing with my assessment, I'm gonna explore temporary pulses. It's palpated 2+. I'm also gonna tell my patient bite strong. So when I say that, I exploring cranial nerve number 5, pretty good. And continue exploring the face. I'm gonna look for any abnormality in the skin, any asymmetric movement. Exploring also cranial nerve number 7. I'm gonna look for any change. In this case, I don't see anything. So now we're gonna continue with the eyes. In the eyes, I'm gonna look for exploring cranial nerve number 2, ophthalmic. And for that, I'm gonna use the Snelling chart. Doing the Snelling chart, I check visual acuity. It was done before we started exams. And the patient reflect 20/30, which means normal. We recommend what we do is put the patient 20 feet away from the Snelling chart, and the patient start reading the letters. First occlude one eye, then another one, and then both eyes opened. And in this case, was normal, was 20/20. Also, we check vital signs. This is a patient with a high 506, weight 145, 65.7 kilograms, BMI 23.4, which means normal. BP 109/66, heart rate 88. Respiration 17, temperature 36.8, oxygen 99, pain level 0/10. Do you feel any pain?
No pain.
Eric? No pain. All right, continue with that. We're gonna explore peripheral visions. I'm gonna tell my patients, I'm gonna wiggle my fingers. You're gonna say right or left.
Right. Left. Right. Left. Right.
All right, perfect. Doing this, I'm gonna exploring cranial nerve number 3, 4, and 6 through oculomotor abducent. Oculomotor cranial nerve number 3, cranial nerve number 4 is trochlear, and cranial nerve number 6 is abducens. Also, I'm gonna check sit Gary Fields, and gonna tell my patients, do not move your head. You're gonna follow my thumb fingertip, and all right, pretty good. Excellent. Now you're gonna do the same thing for the other side. So what we see here, Cranial number 3 sits, 4 sits are intact, no sign of estrabismo, no sign of normality movement, so which means it's good. So continue, I'm gonna use ophthalmoscope to gonna look for red reflex. In this case, I don't have one. So for the red reflex, we're gonna look inside, looking for the red reflex. Also, we're gonna look for the optic disc, and we're gonna look for any arteriovenous malformation, any sign or hemorrhage or edema inside. In this case, negative. We did in both sides. We compare, so that part is normal. And we're gonna look the sclera. The sclera is supposed to be white and shiny. It's normal. We're gonna look for conjunctiva. Conjunctiva is pink, moist. Any alteration in the cornea or in the iris, which means it's intact, it's normal. We continue, and now we're gonna explore ears. And the ears, we're gonna look for any what the implantation of the headphones, anything that may suspect any asymmetric or anything like that. In this case, is intact and the skin very down. Sorry. That's normal. And now we're gonna proceed to palpate to see, to look for any tendon or anything like that. Do you feel any tendon? No pain. Okay, that's good. And now we're gonna use otoscope. And with the otoscope, we're gonna look inside. With looking inside, we're gonna look for external canal, and we're looking for the external canal, looking for any rash, redness, or any occlusion like a serum or anything like be occluding the canal. And also we're gonna look for the membrane, tympanic membrane. Looking for the tympanic membrane, we're gonna look for any bulging, any sign of perforations. Also, we're gonna look at the color. The color is supposed to be a gray, pale gray. No any sign of translucent. No any sign of perforation mentioned before. And we're gonna look for the cone reflex, and the cone reflex is gonna be in the right side at 5 o'clock, most 7 o'clock in the left side. Continue exploring ears, and we're gonna check for the diapason, the fork, and we're gonna explore Weber test and Brenner test. Weber test, we're gonna agitate the diapason, we put it in the middle. Is the patient supposed to feel lateralized, bilateral equal, and it's supposed to be normal. For Brenner test, we're gonna tell the patient, we're gonna put the fork and the sternemastoid process bone in the back, and the patient gonna say if it stop feeling it, and then when you stop feeling it, we're gonna put it in front of the ears. In this case, it's normal. When it it's still feeling it, which means air conduction is greater than bone conduction. We're gonna do that. Tell me if you do. When you stop feeling it. Yeah. Okay. Is it feeling?
Yes.
All right, perfect. So that's that's good. The test is good. Something that I forget that I'm back and forth is in the ear. I had to support the pupil using the pen light. With the pen light, we're gonna see how the pupil reacts to the light. So when I put the light, the pupil contracts. But the funny part is supposed to do the same thing in the other eye. Okay. So we see the patient parallel pupil equal round reacted to the light accommodations. Continue with the ears. We explored before what we described. We're gonna go for the mouth now, and now in the mouth we're gonna look for the lips. Any ulcer screen is skin breakdown or anything that suspect any infections. In this case, the lip is pink, moist, no sign of alteration. Now we're gonna look inside, open your mouth. All right, I see your teeth. There's no sign of a caries or any abnormality. We're gonna look for any plaque or any alterations. And now we're gonna stick your tongue out. Say up. Okay, saying that, we're exploring carotid number 9, 10, and 12. The patient speak pretty clear without any abnormality. Swallow wall. And we see the uvula going up, and we see also the gag reflex present as soon as you start touching the back of the pharyngeal. So was the gag reflex intact present, normal. And also we'll look at the palate, the soft palate, hard palate for any alteration, abnormality, and the tonsils. The tonsils supposed to be equal but both sides, free of exudative tissue like plaque or anything, or anything that suggests any infections. In this case, normal, can then 12, we explore through the movement of the tongue, stick your tongue out. Pretty good, move to one side or the other. Okay, pretty good. And now we're gonna do our facial, cranial number 7, facial. Smile. Alright, pretty good. Raise your eyebrow. Pretty good. Pop your cheek. Good. Nothing asymmetric visible at this point. So which means cranial number 7 is intact. Continuing. Now we're going to your nose, and the nose we're gonna look for any deviation of the septal talicle. In this case, symmetric. Do you feel any pain or anything? When I touch you, just let me know. Alright. Do you feel any pain?
No pain.
Pain?
No pain.
So what we're looking was frontal area is the sinuses, and the maxillar area, looking for any sinus or sinusitis, and which means negative and no sign of sinusitis. And now we're going to explore inside the nose, looking for the mucous. First, we're going to explore olfactory cranial nerve is the number 1. So occlude 1, breathe in, pretty good. Do the same thing, the other one. Alright, with the otoscope, we're gonna look inside, looking for the mucus, and the mucus is supposed to be pink and moist, no sign any occlusions, which means it's intact. So at the end, olfactory cranial nerve number 1 is intact. Continue with the neck. We're gonna look for any alteration or any abnormality, no see any pulsation. So we're gonna palpate, looking for the thyroid glands. We go in the back part. We tell the patient lower the head. We move swallow. So in this case, no visible any, no palpating, so any cyst that can say or any hyperplasia of the thyroid gland. So tracheal milk gland. We're gonna do at this point palpate lymph node. We started from the preauricular ones, post-auricular, occipital, submental, submandibular, tonsillar, superficial ones, and supraclavicular. In this case, at this point, I didn't feel anything, so no adenopathy present. And now we're gonna palpate the carotid pulse, one first, and then the other one, never both at the same time. And we're gonna listen for looking for bruise. In this case, free of bruise. It's more typical of a patient with the stenosis of the arteries. And he's free, intact. And now we're gonna look for upper extremity. So we're gonna check lymphatic node in the axilla, looking for any adenopathy. In this case, no. We do the other side part too. In this case, negative. And now we're gonna check for range of motion in the upper extremity. So I'm gonna tell my patients, raise your arm, okay, move it to the other side, put it back, move it toward you. Now with that's pronation, supinations, flexion extension of the arms. Now we're gonna check the shoulders, do the movement up and back, rotations. So we see range of motion is normal, no any alterations. And now we're gonna explore muscle strength. All right, push to yourself. All right, squeeze my hand, pretty good. Muscle strength, upper extremities is intact, 5/5 is pretty good. And now that I'm doing upper extremity, I'm gonna check light touch in the upper extremity, sensibility, to see any alteration. You're gonna say if it's a dull or sharp. Close your eyes.
Sharp. No. Sharp. No.
Perfect. So we've finished with this part. Upper extremity intact to light touch. And patient is able to recognize sharp or dullness objects. We continue now with the thorax. I'm going to recommend the patient to remove your t-shirt. All right. The upper, we're going to see upper part of the skin, any alteration, breathing abnormality, in this case symmetry, which means good, no skin breakdown, no pulsations. And we're going to start palpating the posterior area until 99.
99, 99, 99.
So in this case, normal parameters, and now we're gonna look for any auscultation of adventitious tissues in the upper posterior part. Breathe in. Breathe in. All right. Say 99.
99,
All right.
99.
All right. What we're looking was bronchophonia, agophonia. Agophonia, the patient say E. Normal patient in this case, E is her. 99. When he say 99, I was listen, and it's barely. That's a bronchophonia. Barely can hear what he was saying. Now looking in the front of the chest, we're gonna assess bronchovesicular, vesicular, and bronchovesicular, bronchial, bronchovesicular, and vesicular lung sounds. In this case, also we're gonna be exploring cardiovascular ones, aortic, sacral space, the costa, right intercostal area. That's aortic. Pulmonic is left intercostal space. Sacral intercostal space, left side sternal area. Air point is more in the left side, third space intercostal area. Tricuspid is more in the fourth space, left intercostal area. And mitral point is mid clavicular line, fifth intercostal space. So we're gonna listen. Breathe with your mouth. So that's bronchial. Breathe. All right, that's bronchiovesicular. And vesicular. Lung sounds are normal, no sign of adventitious tissue like bronchi or crackles or wheezing. And now I'm gonna listen the heart murmur, heart sounds. We explore heart rhythm is regular, no sign of murmur, no presence of fragments or a sign that I say that has present any alteration of the valves and any valvulopathy. And in the mid clavicular line, fifth intercostal space, the point PMI, where you can assess the heart rate. You can, in this case, is a rhythm. You can count for 15 minutes and then multiply by 4. It's gonna tell you the heart rate. Continue with the peripheral ones. We're gonna look for pulses, brachial pulses, radial pulses, in both sides, and then we're gonna compare. And when we compare, we're gonna make sure it's 2+ bilateral and equal. In this case, normal. And then we're gonna check for capillary refills. And the capillary refill is supposed to be less than 3 seconds, which is normal. Continue with the assessment. We're gonna check now the abdomen. I'm gonna recommend my patient lie down. And always check the abdomen, check the skin, looking for any tumoration, any pulsations, any abnormality. And then we're gonna, before the palpate, we're gonna start listening all the quadrants. So to listen all the quadrants, you can see bowel sounds. The bowel sounds supposed to be normal, between 5 to 30 clicks. In this case, normal active. Now we're gonna start percussions. And percussion we're gonna do all the way clockwise. And you feel the difference. In the difference, they tell you all the quadrant most of the time is tympanic, which means normal. And some area where you can find dullness, like in the right upper quadrant over the rib cage, where you can find the liver. The liver is feel like a dullness. Now we continue with the palpation. The palpation superficial and then deep. We're gonna ask if the patient feel any pain, looking for any pain. Then we're gonna do more deep, looking for any visceromegaly. we're gonna look for if the bladder is distended, which is typical of occlusion or any abnormality that can be distending the bladder while the patient is not peeing. Continuing, we're gonna check the costal vertebral angle, looking for any sign of tenderness or pain. It's a typical morning pill and feeding on the lithiasis of the patient. Go back a little bit. In this case, free. And now we're gonna check the lower extremity. We're gonna tell my patient, open your leg, rotate it. All right. No sign of obturator. It's a typical and appendicitis. When we check also the abdomen, we look for peritoneal reactions. It was free, no sign of appendicitis, Maborne or amorphic sign, typical cholelithiasis. Continue checking lower extremity. We're gonna look for hips, patellar area. We're gonna look for ankles. We're gonna look for any swelling. I don't see any swelling. I'm gonna tell my patient move, push me. Okay. What I'm doing here is checking muscles strange. So in this case, the patient has 5/5, lower extremity is strange. I'm gonna check for light sensitivity. I'm gonna touch my patient. He's gonna recognize if it's dullness or sharp. All right. Close your eyes. Let me know.
Sharp. Dullness. Sharp.
All right. Perfect. It's good. Lower extremity. Checking that part, we continue with checking also peripheral vascular system, and we're gonna check for pulses. We're supposed to check femoral pulses, popliteal pulses, dorsalis pedis, and posterior tibialis. We're gonna do bilateral check. We can feel it both at the same time. Compared, it's supposed to be bilateral to plots both sides, which means good. Now we're gonna do range of motions. We want to make sure the patient don't feel any pain, any crepitation on the knees, which means in this case he doesn't feel anything. So now we're going to explore. All right, now I'm going to tell my patient close the eye. I'm going to give you a couple objects, and he's going to recognize what is that. And please close your eyes. I'm going to give you something. And you're gonna mention it. You're gonna name what is the object's name. All right. What is that?
Water. Okay.
All right. Perfect. What I was doing a theranosis. A theranosis allowed me you give it something to the patient. The patient then need to recognize what kind of object is that. And now I'm gonna explain part of the spinal. So I'm gonna tell my patient to stand up. And doing that, I'm gonna tell my patient to bend forward. When I say that, I'm gonna look for the looking for any kyphosis lordosis abnormality or any scoliosis signs. Go back, and now you're gonna move backward. All right, pretty good. Move to your left side, right side. So any pain or anything?
No pain.
Okay, in this case, movement motion of the vertebral column is normal, no abnormality, no sign of scoliosis, no abnormal kyphosis or lordosis. And now I'm gonna tell my patient to walk to see the gait. So you're gonna walk heel toe, heel toe, heel toe. All right, heel toe, heel toe. All right, you're gonna backward. Perfect. Stop. And now you're gonna explore. We're gonna explore coordination. In the coordination, I need that you close your eyes, and look at me first. And now you're gonna close your eyes. You're gonna touch your tip of your nose. All right, go ahead. Pretty good. Change your position. Use the other hands now. Pretty good. All right, now open your eyes, and now you're gonna stand like this is rumbar two. All right, pretty good. Then the other side. Beautiful. Now you go lie down a little quick. And now with this, with your heel, you're gonna move against your shin, and you're gonna change it. Do by yourself with eyes closed. All right? You understand what I say? So you, with the heel, okay. All right. Do it with you. Do it one more time. All right. Perfect. That's our lowest coordination. That's a roamer. Pretty good. Put it down. And now I'm gonna explore one more. I'm gonna explore deep tendon reflex. The biceps and the brachioradials are exploring C5, C6. And the triceps explore C7, C7. Sorry, C7, C8. And now, lower extremity, I'm gonna check patellar reflex, which is explored L2, L4. Always bilateral, okay? And we're gonna explore Achilles tendon reflex. And finally, we're gonna explore Babinski reflex. So in this case, the tendon reflex are intact, present, normal, right? And Babinski reflex is negative, which means normal. The patient is supposed to be dorsiflexion with their toe, which means good. This is my whole physical assessment, my head-to-toe assessment. Thank you for participating, and wish you all the best.